Welcome to Road to 250. Today we'll be doing some practice questions.
An 8-year-old boy is brought to your office because he had developed some facial swelling and his urine was unusual color. On physical exam, he is found to have moderate periorbital edema and mild hypertension. His mother states that, other than a sore throat 2 or 3 weeks ago, he's been in good health. Urine analysis reveals proteinuria with RBCs, white blood cells, and cellular casts. Serum creatinine levels are increased. The most likely diagnosis is which of the following? APSG.
Mm-hmm.
Well, be PSGN.
Rapper.
Correct. And the explanations are on the next page, but I think you guys are pretty good with this one.
How would we diagnose it?
Like the urine analysis?
Well, I guess it's actually technically a clinical diagnosis, but how would you prove that it's post-strep glomerulonephritis?
The urine creatinine? No.
Well, wouldn't you ask about the previous health history?
What labs can we order? Which we probably would never do in real life, but it would prove that they had strep.
Oh, ASO titers.
There you go, anti-streptolysin O titers. I'm trying to incorporate step 2 stuff here. That's for me.
That's good.
Stuff. Yeah.
All right, the nephrotic syndrome is characterized by severe proteinuria, decreased serum albumin levels, and edema. The result from damage is to one or more components of the glomerular capillary wall. In particular, the glomerular basement membrane is essential for maintaining serum oncotic pressure. In non-pathologic states, which of the following properties of the glomerular basement membrane prevents albumin from being freely filtered into the urine?
B. I know that the peptidoglycans have a positive charge. I guess small pore size too.
Okay. Any thoughts here?
Yeah, I want to say maybe B as well.
Okay, the answer is not B. So, do you guys want to retry, or do you guys want to just know the explanation?
Oh, wait, is it C?
The answer is A.
Okay.
So, here you're talking about your fenestrated capillaries, and as well as, so what makes up the basement membrane, or basically the filtration barrier? There are 3 things that make it up. It's your basement membrane, it's your endothelial fenestrae, and then you also have your podocytes. Those 3 things. So I discussed this in my lecture, but the size barrier is one of the biggest things because obviously it's small pore size, so it doesn't allow anything to be very big to get through. But it also, all the layers contain negative charge glycoproteins that prevent negative charge molecules from entering, such as albumin, because albumin is a negative charge protein. So it doesn't allow negatively charged, two negative things will just repel.
Yeah, so they repel each other. Okay.
That's why the answer is.
So it's the basement membrane and albumin are both negatively charged?
Correct. Yeah.
Gotcha. Okay.
And I think in 2017 first aid, it's a bit different. They said all 3 contain negative charge glycoproteins that prevent positive charge molecules from entering. That's wrong, because in 2018 they corrected that and said it's a negative charge. So negative and negative.
Okay, that makes sense.
So does anybody need another explanation for that? Or?
Sounds good. Oh, yes. There's your...
Yeah, I mean, I just gave it to you in words, but it's there.
All right. A 20-year-old Swedish-American man is brought to the physician's office by his mother, who states that over the past year he has become increasingly antisocial. She reports that he is having trouble with academics and playing basketball, both of which he has excelled at in the past. He denies changes in appetite or sleep. He has not had any recent illnesses and has not traveled recently. He does not smoke, drink alcohol, or use illicit drugs. Vital signs are within normal limits. On physical examination, he has a flat effect and limited facial expressions. Pupils are equal, round, and reactive to light, with darkening of the corneal limbus and mild yellowing of the sclera. The liver edge is felt 3 centimeters below the costal margin. He is slow to rise from his chair and uses small steps when walking across the room. Strength is 5 out of 5 in all extremities, although his muscles feel rigid. Lower extremities reflexes are 2+ bilaterally. Results of cardiac and respiratory examinations are normal. Which of the following is the best treatment for this patient? A. Carbidopa-levodopa. B. D-penicillamine. C. Deferoxamine. D. Lactulose. And E. Ribavirin.
B. D. Penicillamine.
Fields.
I'll go with that too.
Yeah.
Boy's got Wilson's.
Yeah. Exactly. Yep. If you click one more time, there's an explanation. But yeah, he pretty much has Wilson. So he has hepatomegaly and jaundice, which are going to be signs of liver disease, rigidity, and decreased facial expressions. This is the classical sign for Wilson's. And so he has the copper accumulation. That was the whole description of the eyes. All right. A 35-year-old man who was adopted as a child is brought to the emergency department by ambulance after having a tonic-clonic seizure at work. The patient reports that he has always been healthy and has never had a seizure before today. He reports having gradual onset headaches during the past month that worsens when laying down. The headaches have awakened him on several occasions and have been accompanied by nausea and vomiting. On further questioning, the patient reports that he has been having intermittent bloody stools for the past 4 months with an associated 15-pound weight loss. The physical examination reveals pale conjunctiva and mucosa. He also has a soft systolic murmur that appears when the patient rises from the supine position. A CT scan of the head reveals a single well-circumscribed mass in the left hemisphere. Which of the following is the most likely diagnosis? A. Familial adenomatous polyposis. B. Gardner syndrome. C. Hereditary non-polyposis colorectal carcinoma. D. Tuberous sclerosis. Or E. Turcot syndrome.
E. Turco.
Yeah, it's that one. I agree.
Mm-hmm. Yeah, so
CNS feature plus the...
Yeah, it's
Yep.
FAP plus the CNS.
Yeah, exactly. And then if you guys do want further explanation, the next slide does have the details.
What is so Gardner syndrome?
Gardner
One
syndrome.
has extra teeth and
Yeah, supernumerary.
The pigmented epithelium. The retinal.
I know, yeah, like you said, supernumerary teeth, but I know there's something else with Gardner.
They have the retinal pigmented epithelium.
So your eyes just get super dark?
It's like a congenital hypertrophy, I think, of the retinal pigment epithelium. Yeah.
As their eyes get darker.
And I think they also have like soft tissue tumors, if I'm correct.
And Gardner's? Yeah, I think those were. Alright, this one's me. 31-year-old gravid 1 par 0 with a history of hypertension presents to the ED because she believes that she's in labor. She's in her 38th week of pregnancy, and her course has thus far been uncomplicated. This morning she began feeling painful contractions and noted vaginal bleeding. She's experiencing lower abdominal and pelvic pain between contractions as well. On exam, she's afebrile. BP is 145/85, heart rate 102, respiratory rate is 16. You note a gravid hypertonic uterus on exam and moderate blood in the vaginal vault. Ultrasound reveals no abnormalities. Which of the following is the most likely diagnosis? Abruptio placenta, phase of Previa, placenta previa, chorioamnionitis, or onset of normal labor. And I just realized I don't have A through E on there, but...
Hey?
There's A, and there's E, and everything else in between.
Any other guesses?
Let's say A too.
Alright. Yes, the answer is A. And your tip-offs for this are that she has painful vaginal bleeding. And the other important thing is that it is in the third trimester. It is after 20 weeks of gestation. So it can present as, or, she's in her 38th week, so she could go into normal labor. But the vaginal bleeding is abnormal. Normally, if a woman's going into labor, you're going to have that gushing, my water broke, gushing of amniotic fluid coming out. So, and the having pain between contractions is also the giveaway here, because normally the only painful part of a normal labor should be during the actual contractions. Vasa previa and placenta previa, they both do also present with vaginal bleeding, but it is painless vaginal bleeding. And again, after 20 weeks gestation. And then chorioamnionitis, she would have a fever associated with these symptoms. So, A. All right, another OB. 28-year-old woman, gravida 2, para 1, at 29 weeks gestation, presents to the obstetrician after noticing red spots on her undergarments over the past week. Her previous child was born by cesarean section. She denies any pain associated with this spotting and contractions. She endorses feeling fetal movements. She has received routine prenatal care up to this point, and her pregnancy thus far has been uneventful. What is the diagnosis that must be ruled out prior to the patient being examined?
Well, she's had previous C-section, so she's had a previous kid, and she has non-bloody or non-painful bleeding. Not bloody. So, yeah, answers. See?
Right, and like Yash just said, a risk factor for placenta previa is prior cesarean sections. Again, this is just because you're creating scar tissue on the uterine lining, so there is less space for a for a fetus to implant the placenta, and so the placenta might try to migrate further down towards the internal os. We already went over placental abruptia. That would be painful. Placenta accreta would present as postpartum hemorrhage, because there'd be retained fetal parts, placenta that won't detach from the wall. Uterine rupture also is something that could occur as a risk factor by having prior cesarean sections, although that would present after labor. Normally, uterine rupture happens either during a labor or after labor, and it's like intense pain once the kid is out. And then a threatened abortion. The reason you can rule out threatened abortion here is because she says that she feels fetal movements. Threatened abortion would normally be vaginal bleeding, and mom is saying something like, I haven't felt my kid move in 3 days, so that's why feeling kicking in the belly is actually really important for mom to feel. So, yeah.
Molecular biologists undertake a series of experiments designed to classify proteins involved in various intracellular signaling pathways. During one of these experiments, a protein mixture obtained from a cell culture is separated by gel electrophoresis and subsequently transferred to a filter membrane. Labeled double-stranded DNA probes are then used to detect a specific protein of interest in the sample. Which of the following proteins is most likely to be detected by this method?
Oh,
E?
yeah, E.
Yeah, I agree. E.
It is actually B.
Oh, god damn it.
What?
So,
I don't even know what that one is.
yeah, I don't know what that was when I did this question either. So they're talking about DNA probes for protein. So they're talking about a southwestern blot because they're looking for DNA binding proteins. And the reason it's not E is because it's a second messenger enzyme, so it doesn't really have to do with being a DNA binding protein.
Yeah, it's not a protein, it's an enzyme.
Yeah, so this weird thing that I've never heard of, C. June, is a nuclear transcription factor, and it binds to DNA with the leucine zippers, if that helps anybody, but no. They code for, well, they're proto-oncogenes. I'm sorry, what did you say?
Oh, you said DNA zipper is like topoisomerase, isn't that? Or is that the unzipper? Well, anyway, helicase or something like that. Never mind. I'll shut up.
I think that's a different one, but yeah. So that's basically off this list. That's the only one that's a DNA binding protein. All the other ones are not. So process of elimination, maybe, if you don't know what C. June is. But there you go.
Was this on one of your NBMEs?
No, this was a UWorld question I did 2 weeks ago.
What the fuck?
Yeah.
I'm guessing biochem section.
It's listed under general principles, but yes.
What?
But yes, I mean the DNA probing and stuff is under biochem, so sure. Okay, slightly different direction. A 35-year-old woman comes to the office with malaise and generalized weakness. Her other medical problems include type 1 diabetes mellitus and hypothyroidism, for which she takes insulin and levothyroxine. She eats a balanced diabetic diet and exercises 5 times per week. Physical exam shows mild conjunctival pallor. Laboratory results are as follows. Further evaluation shows a very low vitamin B12 level and a normal folate level. Which of the following sets of physiologic alterations is most likely to be present in this patient?
Alright, so we're guessing she's got pernicious anemia. Oh, vitamin B12 level. Does vitamin B12 show up if it hasn't already been activated by intrinsic factor?
The Schelling test, right? That's what you're talking about.
Yeah.
Well, if you don't have intrinsic factor, your number of parietal cells would increase to produce intrinsic factor.
Yeah, but it's got low vitamin B12. So does that mean that... No, she eats balanced diet, diabetic diet, and exercises, so why does she
It's
have...
due to the loss of parietal cells. If she has pernicious anemia, it will cause the loss of parietal cells.
So it's got to be A or E.
Yeah, A or E is my elimination as well.
Okay, so parietal cells secrete intrinsic factor as well as hydrochloric acid. So then you would have a higher gastric pH and elevated gastrin. So it'll be A.
Yeah.
Correct.
A is correct. So yes, this person has pernicious anemia, and they do the explanation for this one has a little chart that I didn't include, but basically you have the autoimmune response against the parietal cells going on, which is what pernicious anemia is, and because of that you have decreased parietal cell mass since they are being attacked, and like you said, decrease in intrinsic factor causing the vitamin B12 deficiency that we see here, as well as a decreased gastric acid secretion. So the pH is going to be high, and the G cells are going to want to increase gastrin release to try and compensate for that.
Could this be associated with G cell hyperplasia?
I don't know if the G cells would necessarily go through that. I know they, as far as the explanation for this question, they just say that gastrin levels are going to increase, but I'm not sure of the cells themselves.
If you had G cell hyperplasia, then you would have low gastric pH because it's going to keep on cranking out H. And wouldn't you eventually... Also, you'd have increased parietal cell mass because they're constantly being stimulated.
I'll look at that. I don't know. I have a note here that for parietal cell, G cell hyperplasia. Let's double check this.
So I'm going to ask this question again. So if I'm eating a healthy diet, hell, I even take vitamin B12 pills, but I don't have enough intrinsic factor. When you run a test on me, my vitamin B12 levels will be normal. Low?
Yeah, because you can't reuptake it without the intrinsic factor in the terminal ileum.
Ah, so I'm just pooping and peeing it all out.
Right.
Okay.
So that's why that would be low, because you can't reabsorb it.
Gotcha. Duh, that makes sense.
I don't know if this answers your question, Josh, about the G cell, but
Hyperplasia.
if you do have, so I think what's going on in that question is you have a somewhat normal amount of gastrin release in response to not having gastric acid secretion, but if you had hyperplasia going on, you'd have excess gastrin production, leading to parietal cell hypertrophy and hydrochloric acid hypersecretion. So similar to what Pete said.
Gotcha, that makes sense.
Yeah, so you just end up with lower pH in that sense.
Yeah. So it's not going too crazy, just enough to try and compensate.
Would you still see B12 because intrinsic factor would be affected?
Intrinsic factor would be overproduced.
Okay, so you'd reabsorb so B12 would be high?
I mean, probably just based on your intake.
Okay.
Unless you're pounding B12 shots or something, you know.
You'd have lots of intrinsic factor, but I don't know about B12 levels per se.
David, you always do the vitamins, so what's B12 toxicity?
You see the MMA and in the urine.
Methylmalonate?
Methylmalonate, yeah, methyl.
Oh,
yeah,
methylmalonate.
I know the short.
Yeah, when you read it, you know what it is.
Yeah. Yeah, you see it in the urine, and then there's no
that's when
lesions.
Isn't that when you have a deficiency in B12? Not any.
Oh, sorry, you're asking toxicity. Sorry.
Well, first aid doesn't tell you toxicity.
Okay, that means there isn't a recording.
You just pee it out.
Yes, probably just. Because if you think about it, all B12 really is necessary for is to basically to create DNA in order to create cell synthesis. and to make methionine. So if you have extra, it's like, okay, we'll just make more cells.
And no toxic or adverse effects have been associated with large intakes of vitamin B12.
Okay. Let's take your B12 shots.
June. I still have no idea what this thing is. C-June is a protein with, in combination with C-Phos, forms the early response transcription factor, activated by the JNK pathway. I don't know, but yeah, it's a proto-oncogene that can be induced by UV irradiation. I doubt it's in first aid because I don't recall ever seeing it, but
I didn't know where it would be. It's not in the hemonc section. That might be something that, like, Kaplan has in there. Well, whatever. Yeah, I'm not seeing it here. What is the specific thing that C-Jun does again?
it just says C-Jun and C-Phos are nuclear transcription factors that directly bind DNA via a leucine zipper motif. The genes that code for C-Jun and C-Phos are proto-oncogenes, genes that can become oncogenes following a mutation or with constitutive expression. That's all they say.
Yeah, okay, I'll fuck that.
Yeah. I think the only thing from that question is basically struggling to eliminate everything else as a DNA binding protein. The one that was most chosen for this question was RAS.
That's probably the ones that people actually recognize.
Yeah, but RAS doesn't bind to DNA. Beta 1 doesn't bind to DNA. S100 binds to calcium. Phenyl cyclase doesn't interact with that either.
Yeah, even in the Southwestern blot fact in first aid, they don't even have an example. It's like, it identifies DNA binding proteins. Whatever.